Thanks, Brian. Two things I got from that. Obviously, it's very humbling to see how poor the outcomes are for ACHD patients when they're not taken care of by the team. More importantly, it's clear that the adult interventional cardiologists tend to steal the spotlight from pediatric interventional cardiologists based on the Alan Crevier story. So that's that. Next up is Dr. Jackie Kreutzer. This is a very special lecture, and this is really our keynote lecture. Jackie is professor and chief for pediatric cardiology. I've heard about this talk from no less than 20 people, which was given at the ACC, so I'm pretty excited. So thank you so much, Jackie.
Thank you so much, Yves, and thanks for the organizers. It's a pleasure and an honor to be here with you guys today. And although the subject of this part of the session is the future, I'm going to take you actually very, very much to the past. And what I'll try to do is I'll go over the history of the contributions of the very early pioneers in the field of congenital cardiology, the women pioneers, touch also on the changing role of women in cardiology over time and some of the diversity of the pediatric cardiology workforce, and compare that with adult cardiology. I tried to find a good cartoon of the evolution of the cardiologist over time, and I came across this one that I thought was interesting. Anyway, so cardiology has been traditionally been a very male-dominated specialty, and even pediatric cardiology as well. But it is ironic that pediatric cardiology actually started primarily as a result of pioneer work of extraordinary women that I'm going to refer you to. So we're going to go back really, really early, when we only had the stethoscope and the EKG, and penicillin hadn't even been discovered, and pediatric cardiology started as the study of heart specimens, really teratology. And that's when Maud Abbott created the early foundations of pediatric cardiology. She was Canadian. She graduated from college from McGill University and then wanted to study medical school, getting into medical school. But even though she was valedictorian at McGill, she was rejected because McGill was not taking any women at the time. So she did end up going to medical school at Bishop's College. She was the only woman in her class. And after she graduated, specialized in treating women and children, and developed an interest for congenital heart disease, which at the time was heart specimens. So she became the curator of the McGill Museum. And as you'll see in a lot of these pioneer women, they always had a mentor and a sponsor that supported their career growth. And for her, it was William Osler. As a true, she was an artist. You can see that her description of aortic valve leaflets, disease leaflets, is just amazing. And William Osler recognized her as there had been no collection in North America or in England that came close to it. And that's her drawing of the Holmes heart, a single ventricle, doubling left ventricle with normally related great arteries, that is very historical. So she describes, you can actually get that atlas of congenital heart disease in Amazon now, 1,000 cases with clinical pathological correlation. So it was not only the morphology, she actually figured out the clinical side. And she also tried to interpret why those malformations happened, and brought ideas such as incomplete torsion of the conotroncus could result in heart defects, and had these pretty advanced thoughts on developmental and comparative anatomy, studying other species, the heart in other species as well. These are some of the valve descriptions. They're beautiful. This is a quadricuspid pulmonary valve, and then some aortic valves, diseased aortic valves. And she actually described a case with a spontaneous dissection of the aorta in a bicuspid valve, and she's recognized in the Bicuspid Aortic Foundation for her contributions in their website. The clinical classification is just amazing. So she had acyanotic, cyanotic early, and cyanotic late, and you can see here a beautiful description of coarctation with all the collateralization, vascular rings, and then totally understood tetralogy of Fallot. You can see the nice diagram showing the overriding aorta, right to left shunting, and the implication of chronic cyanosis with clubbing. She even figured out that if patients with a single ventricle who had an L-loop heart, so soleus atrium and ventricles inverted, were at risk of heart block, and she figured that out. And I totally understood Eisenmenger syndrome. So here's the VSD, left to right, and then cyanotic late. There were those who converted because of the high PVR to right to left shunting. So pretty brilliant. Now you can see how tough the times were in those days. This is a clinic, In Montreal, Dr. Osler is conducting in the surgical theater an autopsy, and you can see there's not a single woman. However, she was there, but where was she? You can see she's up there. She's probably the only face that is not illuminated, probably wearing a veil because to cover her face. But that's how it was those days. So pretty courageous to succeed in those days. Was she recognized? She did end up getting an honorary medical degree from McGill in 1910, and she was inducted into the Canadian Medical Hall of Fame. And they had a stamp with her name. It's called the Heart of the Matter. And she was also recognized by Dr. Paul Dudley White as the world's authority in congenital heart disease and a living force in medicine of her generation. So she did get some recognition. The ACHD program in Montreal also carries her name. So we all have heard the true mother of pediatric cardiology is Helen Brooke-Tausig. So she also has a very interesting story. She was born in Massachusetts, and her father was an economics professor at Harvard. And she wanted to study medicine, of course. Now, she went and spoke to the dean of the medical school, and he said, well, you can study medicine, but you can't get a degree. To which she said, well, who would be such a fool to spend 4 years studying and not getting a degree? And he said, no one, I hope. So she said, well, I will not be the first one to disappoint you. And that's when she went to Johns Hopkins. Now, Johns Hopkins was taking women, but it's very interesting, the history. The reason why Johns Hopkins was taking women is because in 1890, when the medical school opened up, they had run out of money. And it was embarrassing because they had all the professors lined up to start working at the Hopkins Medical School, but they didn't have money for the building. And so the board of trustees, four daughters of the board, Johns Hopkins, made this proposal. We can raise the funds as long as you accept women. And that was where Johns Hopkins accepted women. So they reluctantly agreed, and essentially that's why that happened. So she did terrific, got a fellowship in the Heart Station, and then became in charge of a cardiac clinic. She was fascinated by the blue babies and figured out that those that had a continuous murmur did better, and that when the continuous murmur went away, they pretty much ended up dead, so that was fatal. And that's where the thought came about, building a ductus and reestablishing blood flow could treat these cyanotic babies. So she starts thinking of therapy, and in those days, Robert Gross was closing the PDAs in Boston. So she goes up to Boston and asks Dr. Gross, can you build me a ductus? And he said, no way, I'm not in the business of closing PDAs, I'm only in the business of treating them. Not in the business of building them. So in those days, Alfred Blaylock had been recruited to Baltimore, and he was doing a lot of research experiment with his very, very experienced technician, Vivian Thomas. And when Helen went to see him close the first 3 PDAs, she said, well, I stand in awe and admiration at your surgical skill, but the really good day will come when you actually build me a ductus for a child who's dying with hypoxemia. And that's how it ended up. As he was doing experiments anastomosing the subclavian artery to the pulmonary artery to develop a model of pulmonary hypertension, which actually never succeeded, that surgical skill, especially with Vivian Thomas' skill, ended up being the basis for the shunt that saved so many lives. Eileen Saxton was an 11-month-old, very severely cyanotic cachectic child who was dying, and she, with permission of the parents, had the first operation that was successful in 1944. And that was like a boom of therapeutic interventions in congenital heart disease and treating cyanotic kids. It became obviously news all over the world, and that's what we call now the Blaylock-Tausig-Thomas shunt, BTT shunt. So that led to an influx of patients and people to come and learn. She started a fellowship program, and a lot of the future pioneers in our field actually ended up going through Dr. Tausig's training, textbooks of congenital heart disease. And she did get some recognition, no question. You can see some stuff here. She even got the Medal of Freedom from President Lyndon Johnson for her work on thalidomide. I think something that she's often not recognized for, but if you read, Bill Rashkin, who is the father of interventional cardiology, recognizes that her words were very inspiring. After he presented the original cases of the balloon septostomy, which were in animals, Helen Taussig actually wrote to him and said, it would be wonderful if we can do some of the simpler operations without opening the chest. I think that's a real advance and a real look into the future. And he accepts that that inspired him to keep going, because in the beginning it wasn't very encouraging that that would work in a baby. So, and truly, if you look at this, this is really an example of a partnership between cardiology and CT surgery that has really been the theme for our field ever since. That started then. With regards to recognition, these were her words. Over the years, I've gotten recognition for what I did, but I didn't at the time. It hurt for a while. It hurt when Dr. Blaylock was elected to the National Academy of Arts and Sciences, and I didn't even get promoted from assistant to associate professor. So the next generation, I'm going to go a little quick over these. I could want to talk a little more, but Mary Ellen Angle in New York, she had an incredible number of contributions, more than 400 publications in all different, very, very pivotal subjects in congenital heart disease, and also leadership role. And she essentially developed within the American Academy of Pediatrics, pediatric cardiology being a subspecialty. She was also a fellow of Dr. Taussig. I have to talk about Stella Van Praag because she's almost like a mother to me, and she was a very renowned pediatric cardiologist and pathologist who came from Athens to the US for training under Dr. Helen Taussig. And then also John Keith in Toronto, married to Dr. Van Praag, and he says, we got engaged over right-heartedness and married over single ventricle. And then they moved to Boston, where they created a cardiac registry where people from all over the world went to learn about congenital heart disease. And she had that ability to make the most complex heart defects seem very simple and comprehensible to everyone. And especially in those days, the cardiac surgical team who came coming down to figure out what went wrong, because in those days mortality was really high. And that's how you would learn the future. She also made you love congenital heart defects because of her cooking. So there was the homemade bread in the back of the lab, and the smell of homemade bread, and then the formalin at times, but then, and then sometimes some baklava, and in the end, you ended up, for some reason, loving congenital heart disease. She was a proof that a woman cardiologist can be complete, a well-rounded human being, an excellent clinician, great mother, a teacher, wife, and an amazing cook. So she's truly an inspiration to all of us. Across the Atlantic, we have Jane Somerville. So Jane, the tough time she went to an all-boys school during the World War II, and the story is very interesting. But she did have mentorship from Dr. Paul Wood. She was fascinated by Alfred Blaylock and wanted to be a surgeon, but she tells you she had no surgical skills. And she truly was appalled by the disasters of surgery and was a very, very big advocate to detail, accurate diagnosis, had significant contributions in terms of anatomic understanding and clinical correlates. She really started talking about adult congenital as a subspecialty. Now she called it GUCH, grown-up congenital heart disease. That's how it started in the UK. And was very much an advocate of bringing all the subspecialties within the cardiac together, so CT surgery and cardiology in the World Congress, and train people all over the world. You can see this pre-historical picture. Jane Somerville, Mary Ellen Angle, Helen Taussig, and Denton Cooley all together in the World Congress. So, and that's how things moved there on in terms of collaborative with CT surgery. Roberta Williams, I have to mention her at least briefly. She was truly a mother of imaging and echocardiography. All the initial correlates of cardiac pathology with images by echo, angiography, you can see there, transposition. Those kids in those days You came in, had no idea what was going on, went to a cath lab and shoot the high-pressure chamber and tried to figure out what was the congenital heart defect. So bringing this with a 2D echo to try to understand the view to mimic was just amazing accomplishment. And indeed, she was the first director of an echo lab, pediatric echo lab, in the Boston Children's. And interestingly, also the first medical director of a dedicated cardiac ICU. So that was obviously very, very novel. And that was really Dr. Nadas who made that happen. But, and she has, she still goes to conferences. She has a passion of continuous comprehensive care from congenital heart disease from fetal life to the adult. Jackie Noonan with her Noonan syndrome and contributions such as hypoplastic left heart syndrome. Jean Kahn, the first pulmonary balloon valvotomy, that led that when she was 37 years old, so the groundbreaking paper. And then there's many others. Maria Victoria La Cruz with heart development, and I probably can't go into all of these pioneers because of the time constraints. These women had a lot of things in common. They had vision, they had curiosity, they had strength and resilience. Following the steps of these amazing women, we have a whole new generation of leaders in cardiology, whether they're in clinical research, in electrophysiology, interventional cardiology, heart failure, fetal, pulmonary hypertension, and they truly, truly stand in the shoulders of these giant other women who started in the field. My friend Meryl Cohen wrote a column at the ACC and made a reference to Fred Astaire and Ginger Rogers, who danced in some of those many movies in the 30s and 40s, and recognizing that Ginger did everything he did, except that she did it backwards and in high heels. And that sometimes makes us think a little bit about women in medicine. And if you look at women in healthcare in general, about 60% of the workforce, however, when you're looking at CEOs, only 15%, and the same goes on for board members. RO1s as well, significant discrepancy between females and men. Some of the statistics for cardiology, 20% of the fellows are female, and then it's lower when you go to cardiologists in practice. And so even though 46% of the students, graduates, are female in the study, when you go to about trainees, it's 21%, and when you go about board certification, it's 12%. And if you go and look at underrepresented minorities in medicine, it's even worse for cardiology. What happens with pediatric cardiology? Well, you saw the start of the subspecialty, it was all women. But then, when it got interesting, it was taken over by men. And then it was pretty much a male predominant. And you can see this as fellows, how in the last 20 years, there's been progressively increasing in women representation in the pediatric cardiology fellowship training, being about 50-50 now for several years. In this very recent paper, you can see the blue bars are women, 54% in fellows, but as you go from faculty to division chiefs, endowed chairs, et cetera, the percentage decreases significantly. So as you go in leadership positions, it's very, very underrepresented. And in the orange bars, those underrepresented minorities in medicine, which is a lot worse. With regards to compensation, Molly Shah, who's one of the interventional cardiologists in the pediatric world, had a survey at PACES that really demonstrated significantly lower compensation for female electrophysiologists compared to male counterparts, and that adjusted for a bunch of variables. We don't really have a lot of other data. So about 50% of trainees, much, much lower representation in terms of leadership. Let's not talk about CT surgery, that's even worse. Promotion delays, low compensation. But we've come a long way. If you look at the class, how it was and how it is, clearly huge difference. And I think that there's a lot of efforts in place to make those changes continue for a better future. And to give you a little bit of note of hope, we have to remember the recent win for the US soccer team, $24 million in settlement for compensation. So there's really the future. The future is bright, I think. So thank you for your attention.